Stuart, we can see your presentation, we see. Yes, I think we are fine. We're okay.
Stuart, can you put the first slide? Yeah, this one.
Yes, a good afternoon, colleagues. We're most welcome to our webinar this afternoon, where we are going to look at the new labor care guide and respectful maternity care. We've been trying to reach out to quite a number of our panelists. Some of them have some technical glitches, but they should be able to join. I bring you warm greetings from the National Safe Motherhood Experts Committee here at the Ministry of Health, and want to thank you very much indeed for joining on time. It's a great pleasure for us to really be discussing a topic of great importance in terms of how we can improve intrapartum care, intrapartum monitoring for our mothers. And I know quite a number of us have been looking at this tool. It's quite a new tool. However, some centers have already started using it. We want to look at aspects of how do we improve the quality of intrapartum care monitoring. We want to look at how do we incorporate evidence into our routine monitoring of mothers during labor. Issues of respectful maternity care. Right now, as a country, we are grappling with issues of traditional birth attendants. But it's very important for us that to know that as clinicians at the front line of care, we have a very powerful role to play to bring our mothers back, into our facilities, to increase on the percentage of the facility deliveries. We are the primary persons that are going to turn the tide round. And one of the things that we'll be looking at is that respectfulness that this tool also gives us on how it can be integrated into routine intrapartum care. So the panel of experts is going to discuss quite lots of issues. As you can see on your dashboard, you have a section where you can raise a hand. In the interest of time, please note down or jot down your question or comment. You will be able to raise it at the end of all the presentations, so that we can give ample time for the presenters and also to allocate ample time for the discussions. We may juggle the presentations a little bit, and we may have to bring in Professor Josephat Byamugisha to start with, as Dr. Olive joins. I think she had a little messed up the link. Professor Josephat, you would allow me invite you in first. You've done extensive work looking at these two tools, the Partograph that we've used for many years. But we are noticing that, we are having, we have now Dr. Olive. We are noticing that we are not making significant headways. Let me try to check. Dr. Olive, are you able to hear us?
I'm hearing you. Good afternoon, JP.
Excellent. 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 Professor Byamugisha, I'll juggle the schedule back again. So, Dr. Olive, we want to invite you in. We want to invite you in so that you can share with us so that you can share with us your presentation.
Are we together now? Hello?
Yes, Dr. Olive. Yes, Dr. Olive, we can hear you quite well.
Okay.
We want to hear from you, one, on an overview of the new labor care guide, what the frontline health workers need to know within the next 10 minutes. We thank you for reserving time to really join us on this call. Thank you very much indeed. And we want to convey our sincere gratitude to WHO for really investing a lot in this space of ensuring that we have this new tool. And we think that your presentation would really give us that general overview before we dive deep into the rest of the presentations. At this juncture, I would want to hand over to you, Dr. Olive Ssentumbwe, to give us your presentation. Most welcome indeed.
Okay, thank you, JP, and thank you, colleagues who have joined in. At WHO, it has been, I think, a good time of working towards ensuring that we are within and we are answering to the targets of the Sustainable Development Goal 3, where we need to ensure healthy lives and promote well-being for all at all ages. But also, as you know, we are also working towards ensuring that we provide guidelines to support the global strategy for women, children, and adolescents, which is running from 2016 to 2030. And as you know, across the globe, there have been various debates and researches being carried out on normal labor. There have been various areas of work to address the various range of labor practices we have globally. And this has therefore prompted WHO over these decades to review the current practices, and some of which are even increasing use of labor interventions in the absence of clear guidelines. So WHO has come up with this intrapartum care guidance for a positive childbirth experience to ensure that the positive childbirth experience has a significant endpoint for all women who are undergoing labor is really standardized, so that countries, health workers across countries can implement practices which have been recommended and which are evidence-based. So the expert group has now come up with the real recommendations which countries should implement, and the guide, as we shall share with you, at least the summary, but many of you can even access the full document, so that we begin to speak about the importance of women-centered care to optimize the experience of labor and childbirth for women and their babies through a holistic human rights-based approach. This guidance also picks from now the respective maternity care charter, and therefore is expected to be implemented within that broader picture. With the understanding that healthy women, this concept of healthy pregnant women is used to describe pregnant women, including adolescent girls who have no identified risk factors for themselves or their babies and who otherwise appear healthy. So how do we care for them? How do we manage their labor? What must we do? But also as countries, we must be aware that we should look at it within a broad framework, and that is the WHO intrapartum care model, which allows us to look at various areas and implement the guidelines as a package, not just picking out one recommendation. So in effect, we are supposed to understand what that respectful labor and childbirth care is. We should be supporting emotionally these women We should be effectively communicating. We should be able to relieve pain. We should be able to monitor labor systematically and document the events. We should be caring about their nutrition. We should understand whether they want to be mobile or not. And we should be able to establish a referral pathway if we need to refer. So the recommendations, as you will see, will relate to care given throughout labor, the first stage of labor, the second stage of labor, third stage of labor, and what we do for women immediately after birth. This guideline includes 26 new recommendations, and we will examine 30 existing recommendations. And when you read the guideline, it will take you through those which are now recommended, those which are not recommended, recommended in specific context, and those recommended under vigorous research. So it is important for us to reflect that respectful maternity care, which refers to care organized for and provided to all women in a manner that maintains their dignity, privacy, confidentiality. It ensures that we do no harm, we do not mistreat them, and we enable informed choice to be taken, and we ensure that we will give continuous support during labor and childbirth. So this respective maternity care is for everybody, regardless of their economic, cultural background and whatever, and religion. And regardless of whether you think this is a high risk, regardless of whether she's in a hospital or home. Of course, Uganda, we can't offer, I think, very well this monitored labor at home. So we should look at that within our context. And it should be provided by healthcare workers, whether we are in income or high-level income countries. Generally, this care is referring to care organized and provided to all women in a manner that maintains their dignity, as we are saying, in accordance with the human rights-based approach. And it requires interventions at both interpersonal level, between the woman and her healthcare providers, but always remembering that there is a bigger family around that woman. And as we provide this service, we must ensure that we are really working within a dignified environment. And so as health workers, we must continue to explore where we are, how we are working, and influencing the bigger system within which we are working. When they say one of the recommendations is actually supposed to be effective communication, it is important to make sure that we as service providers introduce ourselves to the woman and her companion, and we should be able to address her by name. Mrs. So-and-so, I am so-and-so, and this is what I've come to do. We should be ensuring that the woman and her family have got clear information. We are giving it in a concise manner. We are avoiding medical jargon, as we normally say, like Oliprime or something, you know, on a paramene. We must avoid that jargon. And we should be responding to her needs and the questions she's asking us, and ensuring that the procedures we are going to do are really explained to this woman and her family. The guide, as you'll see as we go down now to fill it, also has a session on the companion of choice. It is now recommended that we should support as much as possible women to have their companions who they feel comfortable with in labor. So it is that person that the woman will choose. It can be a spouse, it can be a female friend, it can be a relative, it can be a community member, and this is where we had a lot of the debate in Uganda. such as a female community leader, a health worker, a traditional birth attendant. And it is important that women's wishes are respected. So that is the first piece, which is care throughout labor. How we should be treating each other and the family around the woman. Now there are specific recommendations also around the first stage of labor, which have been taken on. And we should be working with the understanding that now the latent stage is a period of time characterized by painful uterine contractions and variable changes of the cervix, including some degree of effacement. And at this time in the latent, we are really having very slow progress of cervical dilatation until we dilate up to 5 centimeters. I think that is new. And women should be informed that a standard duration of the latent phase of stage is established or not established. And we must recognize that women are different and they are varying greatly from one another. So the active first stage follows when you're 5 centimeters dilated. And that's a new piece. And it is characterized by regular painful uterine contractions, as we all know. Well, on this forum, there's a substantial degree of cervical effacement. And now there's more rapid dilatation, really, from 5 centimeters to the full dilatation. The duration of active first stage usually should not exceed 12 hours, even within the first laborers. But it can come to 10 hours in the subsequent labors that a woman will have. There is now sufficient evidence to do away with what we have been doing, where the Partograph alert line has been a classifier to detect women at risk of adverse birth outcomes. So it should be noted that the 1 centimeter per hour rule is now inaccurate, given the very many researches that have been done around labor progress. So for pregnant women with spontaneous labor onset, the cervical dilatation rate threshold can be much more than the 1 hour which we were doing before when we were doing Partograph. And if we go back to the old one, we may intervene too early and we may have inaccurate interventions at a wrong time. So this recommendation of not looking at this first rule for 1 centimeter cervical dilatation, 1 centimeter per hour is now phased out, as it was in the Partograph with a 4-hour action line. So we are now looking at a slower than 1 centimeter hour cervical dilation rate. And we should be cognizant of the fact that labor may not naturally accelerate until the cervical dilation threshold of 5 centimeters is reached. Therefore, the use of medical interventions to accelerate labor and birth, such as oxytocin or cesarean section, before this threshold is reached, is not recommended, provided you are monitoring the mother and the baby's condition and you think they are within normal. Another thing that we've been probably some health facilities doing, maybe not in Uganda so much, routine cardiotocography for the assessment of fetal well-being on labor admission or during labor in healthy women is not something we should be practicing. because continuous cardiotocography restricts other beneficial interventions, such as having choice of labor and birth positions, because it puts you on the bed. And yet we know that it is beneficial to walk around freely and remove this stress around labor. Looking now at pain relief during labor, we are all now accepting that we need to manage pain. It's one of the things we need to bring back. But also knowing that pain relief during labor is so dependent on the context within which this woman is laboring, the type of care, the type of communication that we, the care providers, are providing. And if we ensure pain relief based on the choices of women, we may be able to address pain relief in a number of ways. And some of those which are recommended are things like relaxation and massage techniques. I don't know how much we do of that here, but we can continue to learn and explore more. Some of these really reduce labor discomfort and they relieve pain, and they enhance the maternal birth experience. For some hospitals now, even in Uganda, we know that epidural analgesia is being practiced. I think we've come very low on parental opioids. But as you know, these can also be used. And probably there are many of them on the market. I don't know what we can have, what we can promote within our economic environment, but we know that in other environments, there's fentanyl, there is pethidine, which we have always had, and diamorphine, but also looking at what their side effects could be, their undesirable side effects. So it's really a balance, and we need to reorganize ourselves if we are going to use the opioid analgesia more widely than the epidural analgesia for the women in labor. Looking at the second stage, now you have labored, we've given you pain, you are relaxed, and you have reached full dilatation. Women should be informed that now they have reached this stage, since they are now having these involuntary urges to push down, and there will be strong contractions. They should be informed the duration of the second stage, and the women, as we know, will vary from one to another. For women who are having their first birth, it may go up to, according to the evidence available, it may move up to 3 hours, and you are still within normal range. But usually for those who are more than para 1, it should really not exceed 2 hours. We should also be aware that for women with or without epidural analgesia, encouraging the adoption of a birth position of the individual woman's choice, even including upright sitting and so on positions, as many do prefer, should be something that we entertain. We should not be forcing a particular position on women, but we should help them adopt a position where they are comfortable. However, as health workers, we are requested to ensure the that the well-being of the baby is being adequately monitored in whichever position she has adopted. Should there be a change in position which is required based on your fetal monitoring, then we should clearly communicate it to the mother that we are now going to change because these are our findings. So for women with or without epidural analgesia, the adoption of a birth position of the individual woman's choice, including those upright during the expulsive position, is encouraged, but we should be able to monitor this very well. The episiotomy has been now mentioned very well in most of the trainings, that routine or liberal use of episiotomy is not encouraged. There were old practices like applying manual fundal pressure. This one we have all now taught that even this one is really not encouraged. And you should keep saying it under very many environments, because when some health workers are left alone, this may be one of the practices. So looking at oxytocin in after the second stage of labor, the use of uterotonics for the prevention of postpartum hemorrhage during the third stage of labor is really recommended. And the first drug of choice is oxytocin IVIM 10 international units. In settings where this may not be readily available, then we consider other injectable uterotonics which may be appropriate, like ergometrin, as long as you've ruled out contraindications for these particular women. But the use of misoprostol now, 600 micrograms, is also quite common, I think, in Uganda. Another practice we look at this time is delayed umbilical cord clamping, at least waiting more than 1 minute, and probably, and I think now we are saying 3 minutes. If we have these skilled birth attendants and around them, they can do controlled cord traction. However, uterine massage is now not recommended as an intervention to prevent PPH if the woman has received prophylactic oxytocin. So really, in general, if we are going to implement this, if we are going to look at the labor guide that will be presented, we may have to look at what we have. What is the environment we as health workers are working in? Do we have the updated clinical guidance? Are we equipped with the necessary physical resources, supplies, equipment, and stuff? Because many people have voiced the fact that we are working in very difficult environments, and many times that's why it's not possible for us to meet the standards as they have been described. We must obtain partnership, technical support, engage different partners to provide the necessary environment for the health worker to implement the standards that we now know within that broader environment. As I said earlier, it should be a complete package being offered by kind and competent, motivated healthcare professionals. Because as you know, the global survey on what women want, some of the things that those ladies said include that sometimes health workers do not respect them. They say very many negative things. So we must ensure that we service providers are really competent, motivated, and we have access to the physical resources which we need. Each woman should receive her individualized package, and we should avoid implementing interventions without a clear indication. So this is important for us. And I think we've already emphasized that we really need to ensure that if we are going to implement those recommendations, which we have mentioned, and therefore the phasing out of the Partograph and the new labor care guide, which has all those elements which we have seen as recommendations, we must ensure that mechanisms are put in place for all women to be aware of their rights. Because if they are also not aware, they wouldn't ask, they wouldn't request you, and they will remain vulnerable. But we need to keep informing communities, women's groups, individual women in our units that we understand what they need and we are going to be communicating to them. We must be able to have protocols and guidelines. We must be able to have training institutions now revising and teaching these new elements. Professional bodies like many of you who are here seated, the training for intrapartum care can be updated and should be updated. And therefore, we are very grateful to the Ministry of Health and universities now, which are looking at this in totality. We need to strengthen our communication, as you know, and this should be mainstreamed in all existing training units. We've not been strong on effectively communicating with our clients in all areas. It's not only obstetrics, but it's now possible to change and be very clear and put up job aids which help health workers to communicate effectively.
We can summarize, Dr. Olive.
And that is the end, actually, of what you need to be able to implement the overarching WHO model of intrapartum care. And therefore, now I hand over, this is the end of my presentation, to the colleague to take us through the different sessions that are now responding to the guidelines. Thank you very much.
Thank you very much indeed, Dr. Olive. That's extremely very powerful. You've really given us the necessary introduction, and now at least everyone who is on this webinar understands the gist of our conversation this afternoon. Colleagues, without any further ado, I want to invite in Professor Josephat Byamugisha. Professor Josephat is the chair of NASMEC and NASMEC, the National Safe Motherhood Expert Committee, and the director for Makerere University Hospital. He also serves as a senior lecturer at Makerere University Department of Obstetrics and Gynaecology. Professor Josephat, within the next 10 minutes, would be delighted to hear from you about the justification why we should put aside the Partograph and take on the WHO new labor care guide. Over to you, Professor.
Right. Thank you very much, Moderator. Of course, it's very interesting because now you can hear that we literally have to take it on. So I make my part very short. Let me see whether I can be allowed to share these slides. Yeah, apparently I can't share, but I hope one of you will allow me to share so that I can show the few points that are available for discussion. Are you working on that? Okay,
Yes,
very
Professor, I think you should be able to.
And I think now my screen can be seen. Okay, so members, good afternoon. I quickly run through this, and one of the reasons is that a number of us on this forum have really been using or struggling to have the Partograph implemented. And much as talks of retiring the Partograph, but they have called this, should the Partograph be shelved? The reason for this is that you will get one or two people who are still saying that, but are you sure the new one is going to be lighter or faster and easier to use than the previous Partograph that we've had? So that's why I have based it on like, now remember some quick history, realize that Emanuel Friedman started the Partograph in 1954, and this was based on observations of cervical dilatation. Let me put it in a better mode. And that time they were even using stations against time elapsed in hours from onset of labor. So it also had issues of patients subject to perception of contractility, this initial Partograph that was used, but also significant to remember is that there was plotting of the cervical dilatation against time yielded. It is showed and gave out the sigmoid or S-shaped curve. Those initial Partographs had that. And then the station against time would give rise to the hyperbolic curve. So it's good to just remember that. So I have moved fast forward from 1954 to about 2018 and recalled a few things that we actually tried to use. One time we had the national internship package, whereby we called all the specialists in Uganda, at least most of them attended. And the issue there was where we should start the Partograph. Should it be fed at 3 centimeters or 4 centimeters? That was causing a lot of confusion. I brought in this because you realize that with the new guide, even the 4 now is no longer taken up or accepted. So at that stage, we had agreed on 4 centimeters for different reasons. Many meetings have been held. Members, you realize that in terms of training, discussions on how to improve use of the Partograph, a number of publications have been made. And this has been literally in all the low to middle income countries, not Uganda. You will also realize that we even reached the level of saying that maybe if this Partograph is included in the pre-service and in-service, it can be taken up more. Even now, you know that case write-ups include a case of normal labor, where the Partograph must be filled, and also the postgraduates are strongly encouraged to do this. So, but it's also good to realize that we have also had cases where if maybe a fresh stillbirth has happened, there are cases of people trying even to fill the Partograph retrospectively. In other words, during the time when the patient was being monitored, they have not filled it. And there are many questions that why has this really been so? Why has it been such an issue? Well, checked some aspect also about, this was published in African Journal of Nursing and Midwifery 2015. It is challenges experienced by midwives on the use of the Partograph in the Limpopo province of South Africa. You realize that some of the challenges that are mentioned here cut across. Some of them would even say lack of resources such as staff, but then you know that they tell us the Partograph, if staff are fewer, it is easier and better to implement. The time that there is no time to fill the Partograph. Some would even say we don't have the notes, we don't have the Partographs themselves. I remember there was a time we even had to print them out separately and even a photocopy, but then the issue would not be really thoroughly answered. Midwives, and then aspects of understanding of the Partograph, the issue of knowledge, then the skills in terms of filling it. I remember some of my colleagues, some of our colleagues here, for example, Dr. Namagembe has been here and has taught a lot to do with the Partograph, but you realize that even after 3 months, you find people have gone back almost where they were. So what have the issues really been? Is it because it's no longer necessary? Can we get one which is easier to fill? Then there are other aspects like inability to determine the pattern of the fetal heart rate has been an issue that is criticized as far as the Partograph is concerned. And when you look at the picture, it is as if we, the healthcare providers, are being forced to feed the Partograph. It's like the reasons being given are not very much taken up and kind of appreciated by we, the users. So what are the issues? Maybe this is what has made people to rethink and say, could we do it in another way? Now, there is a WHO multi-center study which was done, and what prompted it basically were the many interventions that were happening as far as progress of labor is concerned. And as you can see here, it was PIROS 2018, progression of the first stage of spontaneous labor, a prospective cohort study in 2 sub-Saharan African countries. It is important because you realize that there are some people from Uganda who are highlighted here, Miriam Nakalembe, Josephat Byamugisha, and others, many others, but also the design was international, in although it was implemented only in Uganda and Nigeria for many reasons. And in Uganda, it was basically Kawempe National Referral Hospital and the Malago at that time, because it started when the hospitals were shifting. So I will not go through it. The paper is available freely online, but I suffice to say that it was a prospective multi-center cohort study of 5,606 women with singleton vertex term gestation who presented at less than 6 centimeters of cervical dilatation following spontaneous labor onset that resulted in vaginal birth with no birth outcomes. And this was in 13 hospitals across Nigeria and Uganda. So, well, I have just brought in this, it's called the Markovian analysis, but it is a method used to forecast the value of a variable whose predicted value is influenced only by its current state and not by any prior activity. So why this is brought in, it is one of the methods that was used in that if, for example, a mother has entered the study and is maybe at 7 centimeters, modeling can be done to see what time it would take her to reach 10 centimeters and deliver. So there was that part done, and also survival analysis was used to calculate and get out some models regarding the labor progress and delivery. And this is almost the last slide that I will show, but what I want to bring out, apart from the few challenges that we've been familiar with and have discussed, involved them in training, one other aspect is that mothers do not progress in the same way. So like Olive has indicated, it's difficult, for example, to draw a line and say this is how this mother is likely to progress. And there is a lot of data to this effect. So that is why here they came up with, we came up with cervical dilatation during labor. In the slowest yet, normal women can progress more slowly than the widely accepted benchmark of 1 centimeter per hour, irrespective of parity. Intervention to expedite labor to conform to cervical dilatation of 1 centimeter may be inappropriate, especially when applied before 5 centimeters in nulliparous and multiparous women. So I must say that this prospective cohort is one of those that influenced the current developments in terms of the new delivery and birth guides. So average labor curves may not truly reflect variability associated with labor progression, and the use of the decision-making in labor should be de-emphasized. So this was after lots of discussions in regard to how we should do a remove with the Partograph. So apart from that, the other challenges, that issue that a patient may not follow the alert or action lines, because here those are lines, they may instead follow curves. So it is very important and interesting that members should get this paper and read all the other details that I included, because there is the modeling was done, but also the reality with the patients that were included in the study were actually showing almost this similar pattern, in that they are not following the curves and the lines that are indicated. So mothers could be in any of the, they could be on the left, they could be on the right, but more, for example, we're lying more on the left, because we're also putting like, and now if you put represent a case or a participant with a dot, you'd find they would be more in one of the of the curves. So members to allow and give time to listen to the new guide. I would want to leave this here, but indicate that we have tried to use the Partograph. Of course, the question which I should leave here is that we want to see whether the new tool is easier to use and implement compared to the previous one. So of course, we also don't want to be left behind. If globally people are thinking that we should start looking at labor differently, let's see how this works out. So I would be happy that we have more time with my colleagues who are coming in so that we see and appreciate the current tool and guide that is being pushed forward. So, moderator, let me just leave it at this. I can always take on questions that if it's necessary, but let me allow time to the next presenters. Over to you and thank you.
Thank you very much indeed, Professor. That was extremely very powerful. And you have really approached it with that level of evidence that you've accumulated over the number of studies that you've done around the use of the Partograph. Colleagues, feel free to go into the Q&A section, raise your question, and I would request the panelists, our clinicians on the panel, to respond to those questions in the Q&A as we proceed, so that this can be as interactive as possible. Without any further ado, allow me inviting Dr. Stuart Turanzomwe. Dr. Stuart is an OBGYN resident from Bagala University of Science and Technology. Dr. Stuart, in the next 10 minutes, we want you to take us through an overview, introduction, and definition of the common terms of the labor care guide. Over to you, Dr. Stuart, in the next 10 minutes. Thank you. Dr. Stuart, are you able to hear us? You are still muted. Dr. Stuart?
Yes, thank you so much. I hope you're able to hear me.
Your internet is a bit breaking. Hopefully it can stabilize. But we can hear you. Please proceed. Dr. Stuart, come again, please.
Yes, are you able to hear me?
Excellent. Please proceed.
Okay, my internet is on and off, but I hope you're able to hear me now.
We've lost your slides, unfortunately.
Yes, I'll be connecting very shortly.
Excellent.
So we understand that there are very many complications that can happen during pregnancy, during labor and childbirth, and also in the postpartum period. But what is important for us to note from the various studies is that actually most of the complications that result into death occur at the time of labor and delivery. And this contributes to more than a third of the maternal death that we see in our healthcare settings, and also contributes to a half of the stillbirth, and also nearly a quarter of all the neonatal deaths. Those are children who die before 28 days of life. And from research done, a majority of these deaths occur within low-income countries, where us as Uganda lie. The good news is that actually these deaths can be largely preventable if we are able to monitor these mothers very well and also use a labor care guide to be sure that we are monitoring them throughout the labor process.
Actually, Kajimu can share Stuart's slides. Kajimu, please, if you can share Stuart's slide.
So once mothers come in labor, then we should be able to assess and see if these are mothers.
In progress.
We should be able to assess and see if these are mothers whom we need to start on a labor care guide. And that means we need to take their detailed history, perform a thorough general examination, and this should be able to help us really know the general status of this mother as they come in. We should be able to do an obstetric examination. And this obstetric examination should help us, of course, to assess the status of the baby, but also to perform a vaginal examination. And this will enable us to really look at the cervical dilatation and determine whether this patient is this mother is in latent phase of labor or is in active phase of labor.
Next slide.
Next slide, Dr. J. So once we've done a vaginal examination, then we should be able to determine and say this mother is in latent phase of labor. And like earlier said, these are mothers who have regular or frequent uterine contractions, and they should be having a cervical dilatation that is less than 5 centimeters. The regular contractions is very important. Otherwise, you may be monitoring a mother who actually has false labor. Then there are also those who come and they are in active phase of labor. And those ones usually have regular contractions, cervical effacement, and also dilatation that is at least 5 centimeters. And like we shall be discussing, these are the mothers we shall be monitoring using a labor care guide. For those who are in latent phase of labor, we should be able to keep monitoring them, monitor their fetal heart rate, their general status, and we should be able to review them after 4 hours, and we look at their cervical dilatation. If within 8 hours they are not yet in active phase of labor, then actually we should manage them as mothers who have prolonged latent phase of labor, like we shall be seeing. For the mothers who are in active phase of labor, then we should be able to admit them on a labor care guide, and that is the reason we are here, and we shall have more details on that. So we've already defined that in the next slide, Dr. JB. So we've already looked at first stage of labor that is divided into latent first stage and the active first stage. In the latent first stage, you should look at the uterine contractions, but also look at the cervical changes, focusing on cervical effacement, but also on cervical dilatation. If you have up to 4 centimeters, then that should be taken as latent phase of labor. The active phase of labor, you should still look at the uterine contractions. They should be regular. Then also look at the cervical effacement. This should be substantial, and we tend to have more rapid cervical dilatation from 5 centimeters full dilatation. So next slide. So it is very important for us to note that there are quite a number of differences that we shall see on the Partograph vis-a-vis the labor care guide. Next slide, JB, please. Yes, so you realize that we've been plotting photographs starting at 4 centimeters and moving forward. The labor care guide, the form looks at 5 centimeters for reasons that we've already discussed really, that before 5 centimeters, the cervical change and dilatation seems to be slower, and there were a lot of unnecessary interventions to these mothers. We've been having an alert line, and moving forward, you will realize that the labor care guide has got an alert column, and this alert column actually is at every level, whether you're looking at a companion or you're looking at the fetal heart rate, or you're looking at cervical dilatation or descent, you realize that there is going to be an alert column and an alert at each level of assessment. This has been definitely fixed at 1 centimeter per hour, and in the new tool, this really may not be the case. The previous tool has been having 5 sections, and the labor care guide has got 7 sections, as we shall describe. Next slide. So the main aims of the labor care guide is to guide us to monitor and document the well-being of the mother, but also of the baby, and to guide the skilled health professionals so that we are able to offer supportive care to these mothers whenever they come to us in labor. And very importantly, the labor care guide is to actually help us to avoid unnecessary interventions, especially to mothers who come before 5 centimeters of labor, like we've been doing. So next slide. So the previous slide, please. Yes, thank you. It is also very important that we use the labor care guide to identify and address most of the emerging complications. Like I've already highlighted, there are very many things on the alert column, and this should be able to help us to address most of the complications as early as possible. Next slide. So who can use a part of a labor care guide? You realize that there are very many people who participate in monitoring mothers, and really all of them can use a labor care guide, right out from the students who are under supervision to the midwives, the graduate nurses, the medical interns, the medical officers, the residents, the obstetricians. Really everyone who is taking care of these mothers and is skilled enough should be able to use this tool, as it is an easy tool. Next slide. And this has been designed to be used for mothers who are in active phase of labor, that is from 5 centimeters dilatation, regardless of their parity, but also of the membrane status. So whether they are intact or ruptured, then you should be able to use this tool. Next slide, perhaps that's my last slide. So that is my last slide. I want to emphasize that much as we are talking about the 5 centimeter dilatation, we shouldn't ignore mothers who come before 5 centimeters and you find they are staying 3-4 days in our facilities and there is nothing done to them. So if you identify that a mother has got prolonged latent phase of labor, somebody comes at 3 centimeters, she's still in latent phase after 8 hours, then you should be able to refer them to a CMOC facility. These are facilities which are able to do a cesarean section, but also blood transfusion. And at the CMOC facility, then they should be able to assess why this mother is not progressing to active phase of labor by looking at the 4 Ps, the powers, the passage, the passenger, and also the psychological preparedness. And once that is done, then we should be able to assess the Bishop score and see if this cervix is ripe. If it is not ripe, then we should be able to ripen it using misoprostol. And for those where you find that it is favorable for augmentation, if the mother is suitable for augmentation, then we can use oxytocin. For those who have any contraindication to use of oxytocin, then we should actually be able to do a cesarean section for us to get good labor outcome. Thank you so much for listening.
Thank you very much indeed, Dr. Stuart. Now, Dr. Joseph, could you just dive in and take us through the sections of the labor care guide and the nomenclature and symbols used to fill the labor care guide in the next 10 minutes? Over to you, Dr. Joseph.
Yes, thank you so much, Dr. JB. Right, we shall straight away move on to the next slide, which is which shows us the labor care guide as modified and adopted
for our situation, showing us the different sections that the labor care form has. So the first part is identification of the mother by her characteristics and the status of the membranes and the risk factors that this patient specifically has. For our situation, we have made a few changes and added the PMTCT code, the syphilis, and the hepatitis B serostatus. You will appreciate when we see actually in a subsequent slide, we shall see the actual World Health Organization labor care form. So this is the adopted and adapted. And the second section is to do with the supportive care. In this, we actually have things like, is this patient having a companion? Have we offered pain relief? Are oral fluids provided for this mother? What is the posture? What is the predominant posture for this patient? So this is largely to do with supportive care. And the third section, as highlighted, is the care of the baby, which is more or less the one that we were seeing in the previous labor care monitoring tool. In the baby status, we want to know the baseline fetal heart rate. And as the previous presenter had highlighted, things to do with decelerations, fetal heart rate decelerations. These are really monitored using a cardiotocograph, which is not readily available in all these facilities. So it will apply to those that have the CTG monitors. Then the amniotic fluid, the caput and the molding, if they are there, you should really know that this is supposed to be part of the section 3, which is care for the baby, because these really show us the intrauterine well-being or status of the baby during the labor process. So the fourth section is the care of the woman, and this is where we look at the mother's pulse, the blood pressure, both systolic and diastolic, and the temperature, as well as the urine output. But largely for the care guide, we look at, is there urine protein? Is there these ketone bodies, the acetone, as evidence of dehydration or any causes for us to closely monitor or sense danger. The fifth section is labor progress, which is largely adopted from the Partograph, but with a few changes. We look at the contractions by number and duration. We look at the cervical plotting. We still use the usual X, which we are using, and we also look at the descent of the presenting part, which we use an O, as previously was in the Partograph. That is to do with the labor progress. Then there's some medications if used in decision making. We decision making because it is not paternalistic that the doctor is overriding. You agree with the woman and you let her know what you intend to do with her, given her status, and it is really shared. I request the next slide. So the contents as really elaborated. Section 1 is about documenting. This is trying to elaborate what we have just highlighted. So we can move to the next slide. The section 2 to 5 2 to 5 contains the labor observations for all observations. Let's take note. The next slide, please, Dr. Jamie. Yes, for all observations, there is a horizontal time axis and a vertical axis, which is also known as the alert column. In this column, we observe all observations in the column are deviations from the normal. So at every point of the plotting, when you find any observation that is different, that is the same as in the vertical alert column, then you are expected to mark that, as we shall see. So the second stage section, which was not really elaborate on the Partograph, in this labor care guide, it involves intensive, even a more intensive monitoring, whereby you're monitoring this woman every 15 minutes. You need to assess her. So I ask we move to the next section, to the next page. Yeah, this is the actual labor care guide, the World Health Organization care guide, and the sections are really elaborate as we have just highlighted. So we could move to understanding the nomenclature, the different wordings we use, the language we use on the Partograph, on the labor care guide. So if the membranes are ruptured and you don't know when they ruptured, you may have to to use a U for unknown. Otherwise, you're expected to put the date and time when the membranes ruptured. In section 2, regarding the companion, if the companion is present at the time of examination, you're expected to use a Y for a yes, or an N or a no, and a D if the woman declines. For example, if you ask her, she doesn't have a caretaker, and you ask to provide one if you are able to in some settings, and she declines, maybe she has somebody who she prefers, then you are expected to put a D. Then for pain relief, the same applies as companion, a Y for a yes, an N for a no, and a D if she declines. And oral fluids, the same applies. Posture, which is important for our situation. Indeed, you use an SP for a supine and an MO if the patient is mobile. This is to apply for a patient regarding the predominant posture of this patient. If she's lying left lateral, you may have to use an MO for a mobile, you may have to use an SP you may have to use a mobile because it is less risky. So next slide, Doctor. The fetal heart rate decelerations, this will apply for those that use the CTG, and N still is for a no. E is if there is early decelerations, and L for late decelerations, and if they are variable, then you use a V. This it may not apply to all of us because the CTGs are not really well spread and available. The amniotic fluid characteristics, if the membranes are intact, you'll use an I. You'll use I for intact membranes. C, if the membranes have ruptured and the likewise clear. M for meconium stained, and you are able to grade it as grade 1 and 2, and and use pluses, +1, +2, and +3 or as previously recorded in a Partograph, depending on the level of meconium staining, and use a B for blood-stained fluid. The fetal position, A for an anterior occiput, and P for any of the positions where the occiput is posterior. It may be a left occipital posterior, a right occipital posterior. So you use a P. So if you use a T for an occipital transverse, a left or right, so you use a T. If there is a caput, you use 0 for none, and the others will apply as previously used, the plus or for a mild caput, 2+, and a 3+ for a markedly large caput. Then you use the molding, still language will apply, where you have 0 for no molding and a plus for a grade 1 molding, if sutures are opposed but can easily be reducible, you use 2+, and if they cannot be reducible, you use a 3+. Next slide. All right. Regarding section 4, the urine, you indicate if there is proteinuria, then you indicate a plus, and as usual, the 2+ or 3+, depending on the urine. And if there is no P minus. Acetone, if there is no acetone, you just write an A minus. If there is depending on the strips, then you write as per strips, a plus, a 2+, 4+. Then on the labor progress, that as I said, will apply as previously indicated, is an X and an O for the dilatation and the descent. Oxytocin, if you use these medications, you write N for no and Y for a yes. But if you say yes, then you indicate the units it's provided for, the international units you are putting, and the number of drops per minute. Then any other medications, you are supposed to state Y if yes, and N for no. If yes, then you specify which medications this patient is on. IV fluids, still the same language. Yeah, thank you for the audience.
Thank you very much indeed, Joseph. At this juncture, colleagues, I want to invite in Dr. Godfrey Mugyenyi. Dr. Godfrey is a senior lecturer at Mbarara University of Science and Technology, and he also chairs the Safe Birth and Obstructed Labour Sub Committee for NASMEC. It's that subcommittee that is behind this particular webinar and seeing to it that we improve intrapartum care and monitoring for our mothers. Dr. Godfrey, in the next 30 minutes, would you be able to take us through the feeling and plotting of the labor care guide? Over to you, please. We're getting some background noise from your end, Dr. Mugyenyi. Maybe some more than one gadget are unmuted. You could give it another go, please.
Yeah, we have rectified that.
We still have some more echoes.
No. Are we okay now?
Excellent. Please proceed.
Yes, yes. So I wish to share
We've unfortunately lost you completely.
I request that we share slides from our side because I will use the cursor.
Okay.
Yeah, I'm sure you have my slides. Just confirm that everything is okay and I proceed.
We can see them quite well. Proceed.
So Dr. Mugyenyi is my name, as already introduced by JP. I have been working as the chair for the subcommittee of intrapartum birth. And my tenure comes at a time when we are retiring the Partogram and coming in with a brand new tool that is going to help us move a step forward. I must communicate that the tool that we have been sharing is still in the process of adoption, and the outcomes from this webinar and the comments will give us a go-ahead or even generate comments that should be used. I will also echo on the fact that the partogram that was mentioned to have 5 parts. The 5th part involved the outcome, record for the outcome of labor. On the labor care guide, the 7 parts exclude that. And we have transferred the information that was at the back of our partogram and modified it to put it at the back of the labor care guide for your guidance when you are documenting the outcomes of labor. If you are on the slide that has the WHO labor care guide with me, you appreciate that a lot has been unearthed or presented by Dr. Oliver Ssentumbwe, which really is the guidance, the foundation for transfer from partogram to transition from partogram to the labor care guide. And on the right of the screen, you will see the labor care form as developed by WHO from the user's manual. And the next slide, you will see the recommendations. Some of them will be highlighted by Eva Nyenze on respectful maternity care. And this is a summary list of recommendations for intrapartum care. And most of the issues have been highlighted, like cervical centimeter of 5 centimeters as a cutoff for saying this mother is in active phase of labor, and many other recommendations which will help us to move forward. In the next slide, here you see the 5 parts well demarcated. This one was also very well explained, and I don't want to spend a lot of time on it. There is a record of the outcome of labor, and note that this is in the process of review to capture relevant information. Thank you, partners from EGPAF, who have guided on what they need to be included on the labor care guide to capture PMTCT information. And in the next slide, you will find important notes that regular assessment of labor event is required. Everything that takes place around labor that is very important must be assessed. And unlike in the partogram, in the labor care guide, there is a space to document every little assessment that you will do. There is the decision to intervene, which is based on observation of any deviation from the expected observations. The expected observations are normal assessments. When you take a woman's blood pressure, we know the normal range. If anything deviates from that, then you require to have intervention. The labor care guide provides an express reference value for labor observations, and these are commonly seen in the alert column, which we shall describe for you as time goes by. Also, the labor care guide includes a section to document shared decisions to address any deviations. Whom are we sharing the decisions with? Of course, as usual, we talk to ourselves, to the team, you talk to the anesthetist, you talk to the midwife. The only thing we come in is when there is no spinal needle, and then you start looking for the man to go and buy it, yet you are the one who chased the man in the first instance. So here we are saying shared decisions are not only within the team, we are sharing decisions with the client, the mother in labor, and her companion, and her family member, if such a person is available. How do we use the labor care guide? We must ensure that there is systematic and consistent application of the labor care guidelines, and health providers are encouraged to use the assess, record, check, plan approach, which involves assessing the well-being of the woman and her baby, and assessing parameters that depict a stage where you are in the progress of labor. You must record or document labor observations. You must check on the reference thresholds and compare the labor observations with the reference values in the alert column. If you find any of the observation that you have taken fits in the criteria in the alert column, then you must make a decision there and then, without waiting to make an overall diagnosis of obstructed labor, and then you have lost the mother and the baby. In the labor care guide, you will make the decision when there is a deviation with even one alert. Of course, you plan, decide whether and what interventions are required in consultation with the woman, and document accordingly. If we go to the next slide, it might not be that very clear, but it shows the alert column of the reference. In here, on the left of the page, is an extract of the alert column of the labor care guide. And the alert column presents thresholds for abnormal labor observations that require further assessment and action. If labor observations do not meet any of the criteria in the alert column, labor progression and care should be regarded as normal, and no medication or interventions is warranted. These alert columns are meant to be used as early warning signals and should not replace the expert clinical judgment of the care provider. If, as a care provider, you find something that is very important, please feel free to think through and make a decision, but of course, document it in the shared alert, in the shared section, shared decision-making section. Any parameter fitting the alert criteria is circled. If you do any parameter and you find it fitting in the criteria for alert, you circle it and the best circle will be with a pen that is different from the one that you have been using. And the red pen will be very helpful, like in the examples we shall see later on. If you look at this labor care guide, it has the circled area with green. And this is talking about frequency of assessment. And the frequency is largely similar to that in the previous partogram. We know when you start a woman in labor, cervical dilatation is supposed to be examined every 4 hours. Blood pressure for a severe preeclamptic mother every hour, normotensive woman every 4 hours. All those traditional things are upheld in the labor care regime. It is important that health personnel adapt the monitoring frequency to each particular clinical case and setting. And it depends on the observation made and the status of the woman and her baby. You must personalize every woman and look at her separately, irrespective of other things. If you can see the green circle, that is the area where you're going to put time, okay? In that area, you put time, we shall see the plotted one, and in the purple big box, you see that represents 1 hour from the time zone, from the time section. That big box is representing 1 hour. And where you find a big box, that parameter is supposed to be monitored hourly. If you go down on the yellow box, the purple box, which is big, has been split into 2, and that means the parameters where the big box is split into 2 will be monitored half-hourly. Yes, the yellow box. If we cross over in second stage, I don't know whether that is blue or light blue, whatever it is, that represents half of the hour, so 15 minutes. The parameters which are split into that will be monitored every 15 minutes. If you look at the foot of the table, there is a little bit of plottings in the labor care guide. And for example, this Mary Jane William was first seen at 6 hours, and in the big box, which is supposed to be monitored hourly companion, at the beginning, there was N, which is circled. Whenever you see something that is circled, it means it fulfills the criteria in the alert column. And for companionship, alert is supposed to be N. If you find no companion, that is an alert and you circle it. But 1 hour later, I think the companion arrived and things changed until around 10 a.m. when the companionship possibly disappeared and they circled it. If we go down to fetal heart rate, you see it was monitored every half an hour, and that will continue being guided by the size of the box and how it is split from the big box. If you are filling the labor care guide, you must observe, assess the mother, and get the parameters and put them the way they are. In that area of fetal heart rate, you see at the beginning it was 140, 136, and this is every half hour. You must stay with the mother, at least examining a few things. In section 1 to 4, it is only fetal heart rate that you're supposed to examine every 30 minutes. The rest of the things is 1 hour, like in section 1, and the things in the section of the baby and mother, the parameters in the section of the baby and the mother, you will find that when you do not require to do, for example, a vaginal examination, you might not tell us about the caput or molding, but later on 4 hours, when you're required to do a vaginal examination, you will tell us about the findings in that particular section. If we go to the next section 5, it is about labor progress, and we are looking at the contractions. In the alert column, whenever you find contractions which are less than 2, in a woman who is 5 centimeters, those contractions are inadequate and they will never push out a baby. The baby will come 24 hours later. So you must take action. Or if you find the contractions have just decided to be too many, more than 5, then you take action. That's an alert. In the duration of contractions, if you find contractions less than 20 seconds for a woman after 5 centimeters, it is not normal. Or if you find more than contractions are lasting more than 60 seconds, then they are plotting to rupture the uterus, you must take an action at one particular time. I must say that on cervical dilatation, we plot as usual, but this time we are not looking for the intersection of the X and Y axis. We are putting our X in the middle of the box corresponding to the cervical dilatation and the time of examination. And later on, when you examine the VE, the vaginal exam, the cervix again, you record the new cervical dilatation with an X as usual. Now, there is a very important area, if all of you can see, this is an alert column for cervical dilatation. And in here, we make the diagnosis of prolonged labor. And this is made at any particular cervical dilatation. Whenever you are examining, you must take note of where you were at the previous examination. For example, any woman under your care who is seen at cervical dilatation of 5, okay? And then 6 hours later, this woman is still at 5 centimeters of cervical dilatation. That is prolonged labor at 5 centimeters, and you must go to the guidelines and follow what you're supposed to do. And I'm sure you reassess the 4 Ps. If the problem are the contractions, then you go to the next section and augment labor. For a woman who is 6 centimeters, if she is found still 6 centimeters, more than 5 hours, then that's obstructed labor. Vis-a-vis a woman who is 9 centimeters, 2 hours later, she has failed to make it to full cervical dilatation. That is also prolonged labor. Here, we do not wait for the end to make the diagnosis the way we were doing with the Partograph. Here, it is made at any level of cervical dilatation. Then we go to medications. If you use oxytocin, you put Y. If you don't, you put N at any particular time of monitoring. The medicines, if you use NA, if you say membranes ruptured long time ago, there is an offensive smell and you use an intravenous antibiotic, you put Y, and then you specify which one. And then IV fluids, the same. This section of shared decision-making, we are looking at assessment, the things that you find. And for example, this woman that was seen at one time, she needed pain relief. At one time, it was normal progress, or pain relief was again given until when the woman delivered. In the plan, when she needed pain relief, the corresponding plan was offered companionship and relaxation techniques, and possibly give a labor analgesia or discuss it. and decide whether she accepts it or declines it. And you do that until the span of labor. In the labor care guide, unlike the partogram, has a section where the health worker will take responsibility. And every hour you're examining, or half an hour, there is a shared responsibility section where you are going to put the initials of the person who has done the examination. And every time you examine at the foot, you move from up, down until the foot, where you put the initials for the person who examined. I just want to go a little bit back on this slide and show you something that is very important. From the first hour until full cervical dilatation, we rotate into the zone that is called active fast. The woman reaches second stage of cervical. Fill in that because you examined, plotted down and put X in the labor section at 10 centimeters. And that means the woman has become fully dilated. Now you will skip the remaining space and take the parameters that you found at full cervical dilatation. They will be the first parameters in the line, in the zone that is marked second stage. Whereas first stage of labor, active first stage of labor, is thought to last up to 12 hours, then the second stage of labor shouldn't last more than 3 hours. And this area is there to monitor the parameters in active, in second stage of labor. Still, the big box will represent 1 hour. Half the big box, the parameters there like amniotic fluid and all these will be monitored every 30 minutes. But the parameters around here, where the half box is split, heart rate and decelerations will be monitored every 15 minutes. Now, again, when you go to the section of monitoring labor, you put an X here, meaning she's fully dilated. You have transferred everything there and you continue monitoring the contractions as usual, how many they are in 10 minutes, how long do they last. And when the mother gets the urge to push and starts pushing, there is a box that is in front of the 10 centimeter cervical dilatation. You are going to put letter P when the mother starts pushing. So that at the end of it, and you know, each box is 15 minutes. So if after 2 boxes, the mother delivers, we shall know that this mother took 30 minutes while pushing when she was in second stage of labor. And how do you actually diagnose prolonged labor? I've alluded onto that. Diagnosing prolonged labor is managed at the CMOC facility as it has been mentioned. So if you're at health center 3 and the mother gets into prolonged labor, you make the diagnosis and refer, and the mother will be able to be assessed and appropriate actions will be taken, including emptying the bladder, early rupture of membranes, rehydration, augmentation. Avoid the temptation of doing all of these at health center 3, because the next thing you require is a cesarean section, which you do not offer at your facility. So let the people who can do cesarean section receive this mother in time and are able to help her other than messing her up. Note that taking action for mothers with prolonged labor is not all about doing cesarean section. There are little many things which can be done. If you can do them, well and good, but the majority of mothers with prolonged active phase of labor should be transferred At that time, you have the time to transfer them. Later on, you may not have the time, yet you're not able to do the cesarean section.
We could
Already
summarize,
mentioned
Dr.
that the
Mugyenyi.
labor care guide facilitates you to diagnose prolonged labor at each stage of cervical dilatation. Lasting more than 6 hours at 5 centimeters is a red marker, and it is referred in the red circle. Each of those parameters in the circle at this level will tell you the time that you require to have prolonged labor at a corresponding cervical dilatation. I hope that is clear. This is a well-filled labor care form from WHO users manual. And you see everything that is abnormal that resembles what is in the alert line, in the alert column, is circled. And that means those are alerts. The action, if you see in front of it, you will find something different, and that means the companion arrived. Pain relief, no, she did not have, and then they offered. At this time, it went away, then they offered. You know, with the epidural, you keep repeating and adding doses. The posture, this mother was mobile in the beginning. 1 hour later, she was spine, mobile, spine, mobile. We already mentioned that supine position is an alert position, and you need to encourage the mother to move around if she can, because if she's someone who is on a CTG and is confined in one place, it might not be possible, but the majority of the mothers will be. And you know, when they come to second stage, you know, they are getting into the bed. Within 15 minutes, they are pushing. They might be in supine position, and you put SP and circle it. If you have amniotic fluid that is not clear, that is meconium stained and is +3, that is an alert. So along the way, if you ever find M+++, that's an alert and you need to take action. If you find B, that means that is blood stained. If you go to fetal position and find anything that is posterior or transverse, it is abnormal, circle it, let everybody know, and do appropriate action. But of course, this mother, as fate became, the position changed to anterior and things continued. Caput was never on the partogram, even molding. People were saying, where do we record them? Now it is here. Your caput +1, +2. But if you ever get a caput +3, that is an alert and it should be circled. If you get molding +3, the same. I will not go through blood pressures because you know if it is 140 and above, then it is hypertension, you circle it. The same as urine, they mentioned already. Contractions, if you find contractions which are more than 5 or less than 2, you circle. This mother had good contractions up to the end. Inside the plotting, there is no alert, except if the time goes beyond the expected in order for you to make the diagnosis of prolonged labor. And then the rest as you can observe. Now, we are going to go through a case scenario, and the technical presentation for the labor care guide will be done. This is a case that might be a little bit of for teaching purposes, but this mother called Nansamba Mary reported that MRRH could be Mbale Regional Referral Hospital, but for today it is in Mbarara, and that's her number. She's 26 years old, para 2+1. She's last normal menstrual period, 18th of October 2021. Her EDD is 25th of July 2022, and her gestation is 40+2. labor started on 28th of July, 2022. She was seen in active labor. Active labor was diagnosed on 28th of July, and ruptured membrane, the membranes ruptured on 28th of July, but an unknown time. The mother could not tell us exactly when the membranes ruptured. We looked at her examination. She had anemia and she had had a previous stillbirth. She was TR plus, meaning that she had previously tested HIV negative in our facility, but when she returned in labor, she was tested again and she is still negative. She was negative for syphilis and negative for hepatitis B. This mother was seen at 6 a.m. And when you start the labor care guide and you put the first time here 6, then you have to fill in as much as you can, sometimes up to the end. 06, 07, 08. Remember, this is your alert column, whichever that you are putting in here. If it is fitting the criteria for alert, you circle it. So this mother had no companion, but we encouraged in the shared decision that there was assessment, there was no labor companion, and we encouraged her to get a companion. And in subsequent examination, 4 hours later, the companion was now present. Okay? And the companion stayed until second stage. This mother was not on pain relief. We don't offer a regular analgesia in our labor suite. She was having a flask with her tea and she was freely taking her tea. She was mobile throughout the time. And the baseline fetal heart rate, you can see it was nice and clear. The amniotic fluid, when she was first examined, it was clear, but some hours later, it became meconium +1. We couldn't circle it because it is not alert. Alert is M+3. Her position was anterior. There was no caput, but as we went along at around 10 a.m., she had developed molding +1, and the blood pressures were normal, the temperature was okay, she had no protein, she had no acetone, and she had 3 contractions which continued changing to 4 along the way. They were actually maintained around 4 in second stage of labor. The contractions lasted about 40 seconds. At around the first hour of examination, there was a departmental meeting and people could not look at her for quite some hours. And then at around 10 o'clock, she was found to have a little bit increasing contractions to around 60. And I think this was an alert because it was more than 60 or more. And some actions were taken, the contractions came down. If you look downwards, there was some normal saline as a reaction towards the contractions that were becoming hyperactive. And if you look at the plot, I think around this time when the contractions were about 60, the labor moved faster and we had at least more than 1 centimeter cervical dilatation. And you see she came to second stage quick. Also the descent moved down and the shared decisions were there. She was first seen by Dr. Stuart, and then she was seen and examined by Dr. Mugyenyi, who sent her to second stage of labor, and some plottings were made as usual. And then in this box at around 12:15, it is indicated that birth occurred. And somewhere around here, you can see the time around 11:45, the mother started pushing and she had her birth at around 12:15. And that summarizes our case. We have gone through almost all these things that we have written here. We don't have to waste more time because we have explained them on the labor care guide. The outcome of labor, the mother had a post-delivery BP of 125. Now I can use still the form. The time of delivery, date of delivery, the vaginal delivery, duration of first stage of labor, because this you can easily calculate it. You started here, and when she delivered, when she went into second stage, that's active phase of labor, and you only read the number that is in the box below it. You go to post-delivery blood pressure, pulse, temperature. You go to the placenta. Were there complete placental delivery, yes or no? If it was incomplete. Abnormalities, yes, no, there was none. Oxytocin given, yes. What was the dose? 10 international units. Which route? It was IM. Other drugs, carbetocin wasn't given, but there is a section for PMTCT. This was not a PMTCT. Mother Sonivapin was not given. She bled around 300 mils of blood, and episiotomy was not performed, and there were no tears, and so not applicable for repairs. We offered tetracycline. We gave vitamin K. The baby was alive, scored 10-10, female, weight 3.2, and there were no abnormalities. Delivered by Dr. Stuart, and is a resident, and assisted by Dr. Mugyenyi. In the immediate postpartum care, the mother and baby were well. They were transferred to postnatal care, and we planned for immunization the following day because the mother had to rest, and the breastfeeding was initiated, and the temperature of the newborn was taken as 36.5. And this shows about immunization. PMTCT is recommending immunization of neonates with hepatitis B at birth, according to some guidelines. That's the end. I thank you for listening, and thank you for plotting your first labor care guide with me. Back to you.
Thank
JP.
you very much. Thank you very much indeed, Dr. Godfrey. And this is very phenomenal. Colleagues, we can't emphasize well enough that we need to really ensure that, one, we improve on our monitoring of the mothers. The patient before you is the patient that you have. Giving them that most time possible is very important. But of course, there are other system challenges, which we are saying that everything must be addressed in tandem at the facilities where we are working. Attitude remains extremely very, very key. Attitude of us, the frontline health workers, as we take care of these mothers. However much we put this simplified, and I'm reading through the comments, the appreciations coming through from over 600 people that are attending this webinar. The attitude of you as a health worker, the midwife, the intern, the doctor, the obstetrician and gynecologist with the mother before you is extremely very important for this to work, so that we can see a reducing number of babies dying because of poorly monitored intrapartum care, so that we reduce on the numbers of mothers, of babies, of the fresh stillbirths that we are seeing and the early neonatal deaths, but also the mothers who rupture because we are not monitoring them adequately well. Colleagues, when you look at your timers, we've hit the time that we had prescribed for this, but we will request you kindly, if you can give us an additional 20 minutes. Within 20 minutes, we shall be wrapping up this presentation. At this juncture, without any further ado, I want to invite Sister Eve Wanyenze. She's a lecturer and PhD fellow at the Department of Nursing, Mbarara University for Science and Technology. And she's going to take us through in the next 7-10 minutes through respectful maternity care, which we've seen, and we are appreciating that the additional piece that this brings out is the respectful maternity component. And of course, there is a question, Dr. Mugyenyi, colleagues, Dr. Mugyenyi, Dr. Joseph, Dr. Stuart, please just slide into the Q&A, respond to those questions quickly, because we may have limited time to respond to the hands. And colleagues, I encourage you to now throw your questions into the Q&A. We may have less time to call on the hands. So we will answer them in the Q&A. Dr. Wanyenze, over to you. 7-10 minutes. Thank you.
Thank you very much for the introduction. I'm going to talk about respect for maternity care, and I'll focus mainly on the companion. This has already been discussed earlier by Dr. Olive, so I'm going to summarize this briefly. And just a brief background, childbirth traditionally has been a social, cultural event where women gave birth at home, surrounded by their friends, parents, and relatives. And this gave support to the women so that they could have this event. However, as we know that labor has very many complications, including hemorrhage, sepsis, and asphyxia, among many other conditions. And because of these, women were encouraged to come to health institutions to try and avert some of these complications of childbirth. And most women see this as a trade-off. If they had a choice, they would deliver at home, but most of them come to the hospitals because they fear of unknown, fear of bleeding, fear of losing their babies. So they choose because they have no choice. And a recent study by Dr. Esther at Barrow University found that women prefer delivering at home because they anticipate unsupportive, unresponsive, disrespectful treatment, and a perceived lack of tolerance for simple, non-harmful traditions. And we are saying that we just don't want to count numbers for mortality and morbidity. Women should not just survive complications of labor. Childbirth is an important event in every woman's life, and they remember when and how and who helped them during their delivery process. So we need to enable these women to thrive and reach their full potential. So provision of respect for maternity care is a human rights-based approach to reduce maternal morbidity and mortality. We are saying that's not about just reducing these numbers of women dying, but we also need to offer care with reference to what women want in a humane way. So having said that, we are going to look at this. It has been discussed earlier, but I'm going to dive in just a little bit more. And how do we define this? It is defined as care organized for and provided to all women in a manner that, when we say all women, we mean all women irrespective of the age, irrespective of the parity, irrespective of their socioeconomic status. And this care should maintain their dignity. Simple things like introducing yourself and also addressing the woman by name and not by her parity, not by her risk factor, introduce them by name. Privacy and confidentiality, for example, partitioning the delivery room, and also freedom from harm and mistreatment. And also one that enables informed choice. This involves involving the family members to make decisions for their own. So I'm going to focus more on continuous support during labor. This is my area of study, and I'm going to just dive in this just a little bit. Birth companionship has been recommended, as you have seen earlier, and it is one of the interventions to promote a positive childbirth experience. And continuous labor support, we define it as having trained, it could be a trained personnel, any lay person, a family member that is besides the woman. Somebody asked in the comments, who is a companion? Anybody who is with a woman to coach, to empathize and give practical aid to, and to inform the expectant mother about birthing. This afternoon we're talking about the new WHO labor guide, and when I had a chance to look at this guide, and I saw companionship at the top. I was very excited, and I knew that finally, I think people have now realized the importance of the non-clinical interventions in promoting a positive birth experience. And implementation of companionship, the first step has been taken. It has been integrated in the guide. And as most of you have seen the guide, a big chunk of it is about the small details and looking at these women individually and not as a group, step by step, hour by hour of labor, and not just summarizing the woman as a whole. A part of my findings from my research, and we're talking about women having choices on whether to have the companion or not. I looked at, since WHO had recommended this companion, I wanted to find out what supportive actions that companions give women during childbirth. And also it was important to find out whether these things that the women were doing for them were meeting their needs. As we can see, it's supposed to be a human right. It's not just saying you must have a companion, but what are these companions doing? So just a little about what I found. A larger chunk of the study found that companions were very helpful during labor. They helped the women emotionally, physically, and also a bridge between the midwives and the woman in labor. Emotional helpfulness, they were encouraging the women, they prayed with the women, and they motivated them to be strong. Then physical assistance included giving them drinks, food, walking with them, massaging. We're talking about pain relief. So most people have been raising issues of analgesia, but also the companion is also another component of pain relief. They gave massage, they massaged the back, and this is also one of the interventions they offered. Then also the key thing was that considering the few numbers of midwives, they were an important link, and they enhanced the midwife's instructions. If the midwife is going to give instructions to very many women, the companion helps to propagate those instructions. For example, one participant said, she said, even if the contractions are so bad, don't do anything until the midwife tells you what to do. If you feel like passing stool, that is the baby, do not scream. The contraction will guide you when to push. Then also, there were also some shortcomings with the companion. And like we've said, the woman also has a right to decide when and how the companion should treat her. There were moments when women complained about the way the companions were giving these instructions. One participant said, she says, drink, do this, you are feeling bad, struggling with contractions. She said, drink, really, she should first leave you to relax. So they expressed moments in which they were not responding to instructions and they needed to be alone. So as we look at respectful maternity care, we need to also consider the nitty-gritties of companionship and look at and provide woman-centered care and tailor this care for each and every woman individually according to what they wanted. And then the needs of the women, they needed thoughtful communication. They wanted trust. The companion that comes with them should be able to be trustworthy. For birth companions to anticipate their needs, they thought some of the companions were not meeting what they were supposed to do. And then recognize non-perceptive stages of labor to allow them focus on themselves. This was noticed towards the end of labor when the pains were very intense. They wanted to be alone and they were not able to follow the instruction. So having said that, respect maternity care is a universal human right due to every childbearing woman in every health system around the world. A woman's experience of labor, like we've said, it's a lifelong memory. It can either empower her, comfort her, or it can also inflict lasting damage and emotional trauma, which could affect future reproductive health decisions. And having said that, allow me to end my presentation. Thank you very much.
Thank you very much indeed, Sister Eva, for really keeping the time. That's extremely phenomenal. And sharing. We will definitely, colleagues, have more discussions around the labor care guide and respectful maternity care. We have to still go into the aspects deeply of respectful maternity care plus the labor care guide. So we will create more time and ensure that we add more educative sessions around these two. At this point in time, colleagues, I would want to now take up some hands, maximum of 3 hands. And after the hands, which keep it to the point, keep the question to the question. Do not indulge on other issues. The question should be a question. 3 hands, max. We will have remarks from the Dr. Othniel Musana after the hands, who is the president of the Association of Obstetricians of Uganda. And we will have our webinar closed by the Assistant Commissioner Reproductive and Infant Health, Dr. Richard Mugahi. At this juncture, I would want to now invite the hands. There are those hands that have really been quite persistent. And I really, Lillian, I'll take a hand from Lillian. I'll take a hand from Anna, and I'll take a hand from Ayebare Esther. Those are the 3 hands, unfortunately, in the interest of time that we shall take. Lillian, over to you. If you're available, unmute, to the point, keep it brief.
Thank you very much, Dr. JP, and thanks to the presenters for the good job. I would like to ask about the posture on the new, if I can say, Partograph. Most of us, we are commenting SP for posture, for supine position, but how about other favorable positions that are actually evidence-based? How about if you're looking at standing or sitting or squatting, how are we going to be abbreviating them since they're the evidence-based positions? Thank you very much, and we really appreciate it.
Dr. Mugyenyi, that's your question. We shall first take all the questions and we shall answer at once. Anna Awol, please fire us your question. Anna Awo Asio, are you there? All right, she's not there. Can we take Ayebare Esther? Is your hand still up? All right, it's off. I'll take Motu. Jingo Stephen, give us that question. Keep it brief, to the point.
Okay, yes, thank you so much. Are you listening to me?
Yes,
hello?
Proceed. Yes, proceed.
Yes, I'm Dr. Jingo Stephen, obstetrician here. I'm asking, do we as Uganda Ministry of Health have labor analgesia policy to help us guide when we are managing the labor pain in the labor wards?
Excellent. That's a very great question, and I would invite Professor Byamugisha or Dr. Josephat to respond to that. I'll take one last question from Patrick Sabato. Unmute, keep it brief. Patrick. Okay, can I take one last question from Geoffrey Muhindo? Unmute and speak. Okay, can I take one last question from Walina Joknas? One last question from Walina Joknas. Unmute and speak. All right, so the people I'm calling in are not giving me the questions. Cheyune Frank, are you there? Cheyune, can you unmute?
Hello?
Excellent. Please give us that question.
Yes, I'm Dr. Frank Cheyune. I just want to know if the challenges we have been facing with the Partograph use, they may not, we may not get the same challenges with the use of the labor care guide in this situation with our health workers, because the same challenges may come up again. So we may need more analysis on the why the Partograph actually has failed. Thank you so much.
Excellent. So colleagues, those are enough questions. And I would want to pass the first question over to Dr. Godfrey Mugyenyi, and I will invite in Professor Josephat to respond to the other questions that will be pending. Dr. Mugyenyi, over to you.
Yes, thank you, JP. We are talking about the positions a woman is going to adopt during most of the time in active phase of labor. We are not talking about the birthing positions. There are very many preferred birthing positions for women. In the hospital, we have delivery beds or couches that favor the supine delivery position. Mothers prefer, in a large extent, squatting position. But I imagine if you needed to do episiotomy and examination during that time, we would need aids in the hospital to favor such birthing positions. Otherwise, for now, we are restricted to, in a big extent, the supine birthing position. And Dr. Olive mentioned midwife-led care services at birth, and those are the areas that many developed countries are exploring to find out what helps the mothers to achieve what they think is their calling. In the labor care guide or form, we are talking about the position the mother is adopting in the time during 5 centimeters to 10 centimeters and not the position for birthing. I hope this is very clear. And we are saying if any mother is adopting a supine position that stays in bed most of the time in the previous hour when you're assessing her, then that is not a favorable position. It is supine. You must circle it. It is an alert position. Otherwise, we expect our mothers to be in mobile position, moving around, talking to people seated in a chair, you know, massaging a friend, and, you know, keeping the mother in labor is important. If at all a mother is lying in bed, but is predominantly lying on the left lateral position, or if they are squatting, kneeling, standing, that is still taken as a mobile position, and we shall not circle it. I hope I have answered the question correctly. Thank you.
Thank you, Dr. Godfrey. Professor Josephat, there were some questions that were quite technical that we think you should be able to respond to. One is regarding, of course, the use of labor analgesia. And then the other one is some of the, you presented this partly, but you may want to just allude to it in 2 minutes, why the Partograph has, you know, not really played the role we expected it to do. Professor Josephat. Prof. Josephat, still there?
I'm not sure if he is still there because
you can run over it, Doctor.
Is muted.
You could proceed and run over it. Yeah.
They're asking, we as Ministry of Health, do we have a labor analgesia policy? I am not entirely very sure, because in the current policy guidelines that have been launched, there is no section that captures labor analgesia. There is actually no section that covers obstetric anesthesia. And because of the glaring omission, we have tasked the anesthesia specialists in the country to develop an obstetric anesthesia component that is going to be added as an addendum at the appropriate time. And this is also intrapartum. It is still under my leadership. So we need to get the anesthesia people to avail us with the guidelines. And I'm very, very, very certain the labor analgesia is going to be part of that. And these are academic things. They are WHO documents. So if you're interested, you can still use WHO or FIGO or, you know, certain recommendations and use them, especially in private settings. If they are to be used in the public, then we also need to have the commodities available in the national medical stores, and they need to be embedded in these guidelines before we roll them out. There is a concern from Frank Cheyune that the challenge is faced with the Partograph. Won't they crawl to the labor care guide? We also know that this is a new tool. It has been used since, I think, about 2018. This is around 3 years in some countries. And so far, so good. But I think this is an area for research, documenting practices, especially evidence-based. So we shall not sleep. This is the beginning. We know the Partograph was thought to be cheap on, you know, one full scalp. The labor care guide is the same. It was meant to be easy to use, but I think it was proven that it's not easy to use. In the comments, someone says, from the practice that he or she had in this webinar, that he or she thinks that they are fit to go. So meaning that it is very easy to use. And in the chat section, people are asking, where is the tool? There is a tool that is flying around social media, in our WhatsApp groups, and please get it, print it, avail it yourself, practice, so that when we come to roll it out in your facility, we find you already ahead. Some facilities have already started using it, and even ourselves who are teaching you, every day you learn something new, and that is the way to go. I hope we have answered all the questions, and over to you,
Yep.
JP.
Thank you very much, Dr. Godfrey. Colleagues, I will not take any more hands. We've also maximized the 20 minutes we asked for. At this point in time, colleagues, allow me to invite...
Dr. JP, there is a hand from Dr. Olive Ssentumbwe. I think that's a special hand. Thank you.
Yes, Dr. Olive.
So thank you very much, colleagues. I'll just make 2-3 points. Thank you very much, the presenters. Thank you very much, Mbarara team in general. We have agreed in the past, hopefully with you, colleagues, that we will be taking this forward and ensure that we finalize this adaptation. And we'll be very glad to support this process, as we have said before. And when I say us, this is WHO, will really be willing to take on this so that the health workers in Uganda can be given a final sort of guidance, because we need to have the tool itself, and we need to have the labor guide manual, what helps them to follow through even when they are alone. And you've touched all those aspects very well. So we propose that there will be another session, another meeting to engage Mbarara Minister of Health and partners to finalize this. The second one is that many questions around why we've not done well around the Partograph, but you realize similar elements are there largely. And we did highlight in the beginning that it will require a very motivated, positive health worker to be able to go through the entire guide, as Dr. Stuart Mugyenyi have shown, and others. We will therefore have to do a lot of advocacy to improve our own environment within which we work. WHO guidelines have shown before in the total WHO quality framework that you need a supportive health systems approach to enable you use a guide. it is not only what you know, it's not only your skill, but the bigger environment within which you operate. And colleagues have even talked about the numbers we have. So we'll have to do a total packaging, but advocate that we are given more resources. This will continue. In regard to pain control, I think there has been pain control before, which gradually disappeared from our labor wards. But as recent or as old as the years we practiced, that guidance should be given by the clinicians, the obstetricians, the midwives. And we should try and see what are those recommended medicines available in Uganda, which we need to now go back to. Because if we don't advocate for it, then the national medicines list may not have it as for use for pain control in labor. So that's another area of work. Because this is analgesia, pain control in labor. And we will have to go back to that also and see what is available and with what side effects. So what can we safely use and where can we use it? Lastly, the positioning, as we know, some of the health facilities in Uganda, particularly where this was a very big need. If you visit some of the Karamoja district hospitals, they were enabled, given an environment within which women could sit and even give birth when they are seated so that it mimics their squatting position. They have special chairs in which women labor, and there are also special box-like facilities which enable women to deliver, give birth in that almost squatting position. So we'll have to keep experimenting. What is it that we can do within our settings and within the resources we have? Thank you very much, colleagues, for attending this session.
Thank you very much, Dr. Olive, for summing up with those powerful points. At this juncture, colleagues, I want to invite the president of the Association of Obstetricians and Gynecologists of Uganda, Dr. Othniel Musana. Within 5 minutes, Dr. Othniel, close our webinar this afternoon. Over to you.
Thank you, Dr. Bagala. I hope I can be heard by all the members.
Yes, we do.
This is an area that has come up 2 years ago. We had a CPD session with Dr. Byamugisha, and the question I asked him is that why can't you begin using the labor care guide? And the issue was that there is no guiding policy, and we are waiting for WHO to define itself on the issue. So it's good that now WHO has defined itself on the issue. And as AOGU, we want to be leaders in quality reproductive health. So whatever builds quality, we shall support. And we do this through excellence in practice. So I'm thankful for the Moderator team, Dr. Mugyenyi and company, for proving excellence in practice. We teach people, we do research. Dr. Byamugisha has researched on this topic, and I hope their work bears fruit. And of course, collaborations, and this is an area we need to really focus on. And as AOGU, we've gone into the area of advocacy, not just for our members, but also to ensure that key issues in sexual and reproductive health are actually put to the forefront and implemented. We do have policy priorities, and policy priority 1 is what we are discussing today. As AOGU, our members or membership, including those we work with, have developed some guidelines, reviewed some of them, updated, but also disseminated evidence-based safety bundles. Now, the LCG or the labor care guide is an evidence-based safety bundle that will help improve the quality of care. And of course, priority 4, which is building and strengthening partnerships. And I'm glad WHO is taking this issue up seriously, that we need to actually strengthen service delivery, and the partnership will go a long way in this. Promoting research in practice, I think the team from Makerere and Zambia and the rest who took part in the research to bring the LCG as it is now are actually members of AOGU, and we thank you for that. Then of course, as AOGU and as president, a lot of my issues revolve around advocacy. And we are advocating that the LCG is actually implemented. So LCG is short for the Labour Care Guide for the members, not LCD or LGTV, no. LCD is Labour Care Guide. So it's a key issue. It's an evidence-based issue, and most of the evidence was gotten from the hospitals here. Dr. Byamugisha did not emphasize about that evidence was from Uganda majorly. Most of them were from Uganda. So as you all know from Dr. Byamugisha's presentation, much of the data gathered to support the change from the Partograph to the Labour Care Guide was from Ugandan women. So when we are talking about monitoring labor and the changes in dilatation, these are our women. Our women don't conform, or majorly didn't conform to what we used to say, the 1 centimeter per hour. So I think this should be a fairly easy thing to put out there. Now, the methods used in that study, and Dr. Byamugisha said, please go and read. That study was prospective, and the numbers in the study were actually big. And if you look at the methods used in that study, those methods tended to correct for the previous errors made in studies for labor progress. And as the president of AOGU and also as a ministry and WHO, I think this is a first that where we are translating actual evidence that we ourselves generated into practice. And as such, we recommend that all health workers take up the LCG and we embrace it. I know many people will not support the LCG because they still believe the Partograph can work. So now the Labour Care Guide, of course, will not remove some of the obstacles that failed the Partograph implementation, the poor attitudes, lack of stationary health system issues that will and are still present and pertinent. However, from the evidence that was done in monitoring these women, we hope that it will reduce especially unnecessary interventions that came around because of issues around cervical dilatation and expecting all women to go at 1 centimeter per hour, but also the 2 lines, alert and the action, I think had been misinterpreted, that if you cross the action line, we have to scissor you. If you cross the alert line, labor is prolonged or labor is not progressing well. So I think this study that was done with our women here, I think about 3,000 women, showed that some of those issues are not true. As also an association, but also as practitioners, I think the Labour Care Guide has brought some clarity and is explicit on the alerts. And many of the issues around the Partograph, I think, was a misunderstanding of when to actually either ask for help, to consult, or when to alert, which alert based on the level of cadre. The assumption also was that all health workers actually know how to read a graph. So we based our issues on the graph, but a lot of health workers, even the most senior ones, sometimes have problems reading graphs. So I believe that with going into an alert system, for example, if you look at the baby, the fetal heart, if it's less than that, more than that. If there is meconium staining, what level of meconium will let you alert the fetal position, posterior, and the rest. If you come to the contractions, these are explicit alerts. So if we are doing research and we believe there is a problem around these alerts, then this can be changed because it's the first time they have come out explicitly in writing. The Partograph tended to depend again on the graphs, which may have been a challenge maybe for some health workers. Now, the issue around the progress of labor, the cervix. Many of us had been taught that if you cross this line, then have to intervene. But from the data that was collected locally, it is clear that, for example, at 5 centimeters, if somebody takes more than 6 hours at 5 centimeters, then you may need to reassess. But if the fetus is okay and things are moving on well, then please let the woman progress well with labor. So as an association, but also as policymakers, also as implementers, as healthcare workers, what will actually affect the success of the WHO Labour Care Guide? I think from some of the debates we've been hearing, both online, NASMEC, MPDSR, I think there's a lack of buy-in for the Labour Care Guide by many of our seniors. I won't be ashamed to say the obstetricians, the midwives, and some policymakers, despite evidence being locally generated. So unless there is buy-in, and unless the seniors are going to champion the LCG, I think we may have a barrier in that aspect. So it is of utmost importance to actually then do more CPD sessions and more detailed CPD sessions for the seniors about the LCGs. So most of them do not think we need to move on for the Partograph because some of the reasons Partograph failed are still in existence. So that could present a barrier in implementation and should not be taken lightly. And I think as AOGU, as the universities and members of NASMEC, WHO should factor this in. So for this tool to work, I think many of us were trained by champions. And up to now, using the Partograph has been on the backs, carried on the backs of champions. So who are the champions for the policy, obstetrics, midwifery? Like we had champions for the Partograph, and where the Partograph was being used, most of the things came because of those champions. Another challenge I think that may come in and may be reflected on the questions was that this LCG or the Labour Care Guide dissemination, this meeting actually, this came in at a time when many of the guidelines had been released. And I think most of them were based around the Partograph. So I believe that we need to take steps to disseminate the LCG or the Labour Care Guide and educate the workers more. Then of course, many of the questions being asked by people on the Labour Care Guide are, if the Partograph failed, why should this succeed? I think the issue now is that as the NASMEC, as the ministry, as WHO, we should have some concurrent research moving alongside the LCG introduction to assess enablers, barriers, so that as we move with the dissemination and implementation, a lot of those barriers are captured and then sorted out as we move along with this. Then of course, one of the things that I think we shall need to partner with WHO and other universities and also a lot of referral hospitals is the plan for dissemination, especially around training the mentors. AOGU has many mentors who go out to train BMONC and CMONC facilities. So those mentors, I think, become an urgent matter, and they must understand the importance of the Labour Care Guide. They must understand the tool itself and also how to mentor the facilities and the midwives and the doctors at these facilities on implementing the LCG. So let us factor in those things as we move towards the implementation and the dissemination of the LCG to all MCH facilities. But also in terms of training, I don't think there are few nursing tutors or midwifery tutors who have heard of the LCG when we talk to them. Now, what the Labour Care Guide is not. I think people are assuming that the Labour Care Guide will take away system issues. The Labour Care Guide will take away poor attitudes. No, the Labour Care Guide will not replace clinical decision making. So when you find the alerts have been made, because the alerts here are explicit, when the alerts have been made, then you, the clinician, makes the decision on how to proceed based on what is for you. People have been asking now, how do we do code clamping? How do we do? I think the Labour Care Guide is a tool for monitoring or guiding the health worker in the monitoring of labor, first stage of labor. So it doesn't affect the way we manage active management of third stage or management of second stage of labor. So the Labour Care Guide does not change what we have been doing in those areas. And of course, the Labour Care Guide doesn't replace proper training in obstetrics or midwifery. So as we implement, we need to look at the trainers and also empower them to actually use the tool in training and explain it well in training. And of course, one of the issues we find as AOGU as we go out to either disseminate or implement some programs is the issues of the clinical microsystems. Those small teams in the health facilities, the smallest teams that actually manage the woman, the midwife at Center 2, Center 3, the medical officer, and the support system around that the woman at the smallest centers. These are issues that I think we need to think about how to strengthen that microsystem in order to implement the LCG. The good thing, most of the LCG alerts are very clear and explicit. If it is this, please consult. If it is this, please consult. So as AOGU, we will support all evidence-based interventions that are known to improve care, and that is our stand. So the LCG or the Labour Care Guide is an evidence-based tool, and and I think of importance is that it was derived from within Uganda. The biggest chunk of women were actually Ugandan women. So I believe that as AOGU shall support the ministry, we continue supporting NASMEC and also our partners to ensure that we implement and disseminate the LCG. So thank you very much.
Thank you very much indeed, Mr. President. Colleagues, we've come to the end of our webinar. Our sincere apologies, we have extremely overshot the time, but every single piece that we've discussed today has been extremely very, very important, being that this is a new tool that we are bringing on table. Colleagues, please note that the recording will be shared through the NASMEC YouTube channel, and the presentation will also be shared in your respective emails, all of you who registered with us. We shall have our next webinar under the Safe Motherhood webinar series offered by NASMEC in collaboration with our respective professional associations on the 25th of August, 2022. Please note that the webinars under NASMEC happen every last Thursday of the month between 2 to 4 p.m. At this juncture, I want to really applaud the team of presenters in Mbarara University of Science and Technology, Dr. Mugyenyi, who chairs the NASMEC Subcommittee on Safe Birth and Obstructed Labour, Dr. Olive Ssentumbwe from WHO for really gracing this occasion, Professor Josephat Byamugisha for your expert input on the evidence that has been gathered over the years, Dr. Stuart from Mbarara, Dr. Joseph Rabazibwa, Sister Wanyenze for representing our midwifery fraternity, and the president who has wrapped up everything. It's been great pleasure to have you on this webinar that has closed, regardless of the overshot, with over 400 participants. Thank you very much indeed. I've shared in the chat an email to which any question can be raised, and we will ensure that we respond to every single question that gets onto that email address. Colleagues, have a very fantastic afternoon, and let's take advantage of this opportunity presented to us to improve our intrapartum care monitoring for the mothers that we do serve for the greater good of the mothers and newborns in this country. Have a good afternoon. It's John Paul Bagala, the National Coordinator for NASMEC. Have a good evening.
Thank you.
Thank you and bye.